So my name is Matthew Goldberg. I'm a dermatologist and dermatopathologist and medical director here at Castle Biosciences. And today we're going to be talking about diagnostic and prognostic testing in melanoma and cutaneous squamous cell carcinoma. And we're joined here today also by one of our medical science liaisons, Liz Holland, who will be on the chat as well. So if there's questions, please chime in and we'll be able to answer those questions at the end with time for questions. So again, thank you for joining us today, and look forward to the conversation as well. All right, so as a background for the presentation today, we're going to be discussing a range of tests that are offered by Castle Biosciences. And fundamentally, at this time, Castle has a range of gene expression profile tests that address multiple different cutaneous malignancies in uveal melanoma that present molecular diagnostic solutions really for the advancement of patient care. And starting in 2008, Castle Biosciences developed the DecisionDx-UM test for patients with uveal melanoma that has been incorporated into guidelines for the care of patients with uveal melanoma to inform management decisions. For cutaneous melanoma, we have two tests, a prognostic test, the DecisionDx-Melanoma test, that is intended for patients with invasive cutaneous melanoma to help inform important management decisions. And a more recently developed test, the DecisionDx-DiffDx-Melanoma test, which is intended as a diagnostic aid for difficult to diagnose melanocytic lesions that we'll also discuss today. And then we'll end on another test, the DecisionDx-SCC test for patients with cutaneous squamous cell carcinoma and one or more high-risk features. And taken together, we'll be discussing really the suite of gene expression profile tests that Castle's developed, again, for the benefit of patient care and for the clinicians that are taking care of our patients with these cutaneous malignancies and uveal melanoma. So first, I want to just highlight that the platform that really underlies these gene expression profile tests is similar for each of the three products that we'll be discussing today, but they each start with a different tissue of interest to begin with. So whether it's a difficult to diagnose melanocytic lesion, an invasive cutaneous melanoma, or a squamous cell carcinoma with high-risk features, the analyte here, or the tissue that's being tested, is fundamentally formalin-fixed, paraffin-embedded tissue that's macrodissected, and RNA is extracted from the tissue and then amplified with RT-PCR. At this stage, this is where the gene expression profile tests are then run on this material here that produces a gene expression profile result that's different for each of the products that we'll be discussing, and that fundamentally helps inform diagnostic decisions as well as prognostic information that can help guide clinicians for the management of their patients. But that all of these tests fundamentally have the same development and way that the actual tests are run in the laboratory here at Castle Biosciences. So the first test that we're going to be discussing today is the newest test from Castle, the DecisionDx-DiffDx-Melanoma test that's designed for difficult to diagnose melanocytic lesions. And we recognize that these lesions pose a diagnostic challenge for dermatopathologists as well as management challenges for the dermatologists that are treating patients with these lesions. And pigmented lesions are a main reason why patients present to dermatologists. We estimate that about 2 million biopsies are performed per year of suspicious pigmented lesions that come into the clinic. And this results in about 130,000 invasive melanomas per year and almost 100,000 melanoma in situ diagnoses that are made per year. And what's, I think, missed in kind of identifying just the melanomas and melanoma in situs is that many of these suspicious pigmented lesions result in biopsies that can't be confidently diagnosed with just the H&E tools that we have today. And we estimate that there are about 300,000 lesions where there's a significant amount of equivocation or ambiguity in the diagnosis of these melanocytic lesions. And so just as a schematic for this, if we start on the left-hand side here with these 2 million biopsies that are performed per year, the majority of them are actually of benign melanocytic neoplasms. Here, seen on the bottom row here, where dermatopathologists can give a confident diagnosis of a benign neoplasm and reassure patients that no further treatment is needed, and they can return to routine follow-up. On the high end here in red, these are the melanomas, invasive melanomas, and melanoma in situs that are all treated with a definitive surgical procedure. And then depending on the specifics of the tumor, additional procedures such as sentinel lymph node biopsy can be obtained. And then follow-up decisions such as imaging or increased rates of follow-up can also be recommended, again, based on the specifics of the lesion. And it's at this stage as well that gene expression profile tests can be used to help guide some of those decisions. The focus of the DiffDx test is really in this orange zone here for lesions with uncertain malignant potential, where there's significant diagnostic ambiguity for these cases. And what happens in clinical practice is that the lesions may have a broad differential diagnosis, and clinicians may opt to treat for the worst case scenario in the differential diagnosis, which can result in significant overtreatment of lesions that are fundamentally benign and may not require definitive procedures, and also could lead to undertreatment. If a melanoma is not diagnosed and at the time of initial biopsy, it can lead to undertreatment as well. And so the DiffDx test is fundamentally positioned to address lesions here in this zone of uncertain malignant potential, to add the diagnostic clarity to help guide patient management decisions to better match the biology of the tumor in question. So here's a schematic for how slides are moving through DermPath labs and where the DiffDx test is positioned in that process. So again, dermatopathologists their training is really focused to identify whether melanocytic lesions represent benign or melanocytic or malignant processes. And it's readily identifiable whether additional workup is needed for these cases that are more challenging. And we have many tools in the DermPath lab to help add more clarity, such as immunohistochemical stains, deeper levels, or bringing a case to local experts, whether that's walking a case down the hall or bringing it to a daily consensus conference in the DermPath lab. We can reach a diagnosis of a benign or malignant melanocytic lesion for many cases that we fail to do so on the first pass. However, there remain a significant number of cases where there is significant equivocation or ambiguity, and there are additional ancillary tests that are currently available for dermatopathologists to help, again, add more clarity for these cases. A second opinion can be obtained where the case can be sent to a regional or national expert, or molecular studies such as fluorescence in situ hybridization or array comparative genomic hybridization can be obtained, as well as gene expression profile tests to add more diagnostic clarity for lesions that are difficult to diagnose using the routine methods of immunohistochemistry and H&E staining. And that's really where the DiffDx test is positioned for these cases with significant diagnostic ambiguity. And the DiffDx melanoma test is fundamentally a gene expression profile test that's an in vitro analysis of these primary cutaneous melanocytic lesions for which the malignant potential is uncertain. And as an ancillary test, it really can help to interpret characterize these lesions as benign or malignant in the context of the other clinical, laboratory, and histopathologic information that we have about the case. And when the DiffDx melanoma test can do is that it's a 35 gene expression profile test that's again performed on this macrodissected tissue, and that uses a proprietary algorithm to produce a score of benign with a gene expression profile suggestive of a benign neoplasm, intermediate risk where a gene expression profile cannot exclude malignancy, or malignant profile where a gene expression profile is suggestive of melanoma. And the evidence that supports the DiffDx melanoma test is from published development and clinical validation paper, as well as a first clinical utility study that were published at the end of 2020 in the 2 articles seen below from Skin, the Journal of Cutaneous Medicine. And I'll go through here in the next several slides describing the initial training and validation cohort to describe the evidence that supports the use of this test. So the development effort started with 1,300 benign nevi and 1,500 malignant melanomas that were randomly selected into a study cohort of 951 patients. These cases were subsequently divided into a training cohort and a separate independent validation cohort seen below. I just want to highlight that this first number here, this MGF rate here, speaks to the multiple gene failure rate within the study cohort and highlights only 32 cases that were included in the study cohort were not able to produce a result from the DiffDx assay. And this speaks to a very high rate of technical success for lesions that were in the study cohort and submitted for testing, which we would anticipate in clinical use as well. So the training cohort here was where we'll start, and then the second half we'll focus on the validation cohort. So for the training cohort, what we started were archival benign samples and malignant melanoma samples with concordant diagnoses. And on these samples, this is where we performed the RT-PCR with an expanded set of 76 genes. Now, these 76 genes were subsequently reduced in the training step to a set of 32 discriminant genes and 3 control genes using deep learning techniques and neural networks to refine a 35 gene expression profile locked algorithm. That algorithm was subsequently validated on the independent validation cohort of 503 samples, again producing these 3 scores of benign, intermediate risk, and malignant. So in the training cohort, we included a range of benign nevi and melanoma subtypes that are intended to provide evidence for how this test can be used in clinical practice to differentiate between benign nevi and malignant melanoma. And again, this was the step where deep learning techniques and neural networks were applied to produce the 35 gene expression profile algorithm that best characterized the benign lesions as benign and the malignant melanoma lesions as malignant. In the clinical validation cohort, the 35 gene expression profile was subsequently validated on this separate set of benign nevi and malignant melanomas. Now, the subtypes of nevi and melanomas are the same for the training and validation, but the numbers are different because, again, these cases were randomly included in the training and validation cohort. And they're made up of common subtypes of benign nevi, such as intradermal nevi or dysplastic nevi. And then on the melanoma side, common subtypes such as superficial spreading melanoma and nodular melanoma, in addition to some less common subtypes like desmoplastic melanoma or nevoid melanoma. And in addition, melanoma in situ was included in both the training and validation steps. Concordance was established here for the benign lesions, with the majority of cases being 3 out of 3 concordance, so 3 independent dermatopathologists arriving at the same diagnosis, but also a smaller subset with 2 out of 3 concordance, which I think speaks to the ability for the test to perform in concordance of 3 out of 3 and 2 out of 3 dermatopathologist agreement. And the performance of the test was the same in these cases with these 2 types of concordance here for the benign subtypes. The performance by specific subtype of benign nevus and melanoma are outlined in detail in the paper here from the Estrada et al. And overall, the test was able to accurately identify these benign nevi in the vast majority of cases as benign, with a small rate of intermediate risk lesions and a small rate, again, of malignant lesions that were classified by the gene expression profile test. I do want to highlight here that of the 7 Spitz nevi that were highlighted as malignant in this validation set, 6 of these occurred in children. And as a result, the DiffDx test is actually only available in the adult population, and we have additional studies ongoing to better evaluate the performance of the DiffDx assay in the pediatric population. So the specific performance by subtype is informing where the test is clinically available, which is currently only in the adult population. And I'll speak to that when I go over the performance at the end of this section. For the performance in melanoma overall, the test was able to identify the vast majority of cases of malignant melanoma as malignant with the gene expression profile, with a small rate of intermediate risk, and only 2 lesions that were classified as benign by the gene expression profile test. And this performance speaks to the outstanding performance metrics here in the validation study. In the middle column, we have the performance of the test in the all-age group, and then on the right with the over 18. And I'm going to focus on the over 18 population, the adult population, because this is where the test is currently clinically available, with a sensitivity and specificity of 99.1 and 96.2 that lead to the high positive predictive value and negative predictive value of this assay. And importantly, these accuracy metrics are calculated with only 3.8% of the cases removed that received an intermediate risk result, which speaks to the fact that over 96% of cases that receive a result with the DiffDx melanoma assay in this validation cohort would receive an actionable result of either benign or malignant with a high rate of accuracy in this validation cohort. And so fundamentally, what this test can provide for dermatopathologists and dermatologists are slightly different. So for dermatopathologists, in cases where there's significant diagnostic ambiguity, the gene expression profile can add more diagnostic clarity to reports that can lead to clearer articulation of desired management plans that dermatology colleagues would follow that's informed by a gene expression profile test of the lesion in question. For dermatologists receiving these tests, receiving these results from pathology, the reports can be more clinically actionable so that in cases where there's significant uncertainty, we can add clarity and confidence to the treatment plan that's initiated for these difficult to diagnose melanocytic lesions, informed again by the gene expression profile. And what's more, seen here at the bottom, there can be rapid access to the DecisionDx melanoma assay. And where that fits in the workflow for these difficult to diagnose cases is, again, for these challenging melanocytic lesions that are currently difficult to diagnose using routine methods, as an ancillary test to add additional diagnostic clarity. And DecisionDx melanoma, can follow after the DecisionDx DiffDx melanoma test. So if a lesion that's diagnostically challenging receives a malignant result through the DiffDx melanoma test and is appropriate for testing for the DecisionDx melanoma test to inform important management decisions, this test can be performed with a tissue sparing approach if the lesion is appropriate and is diagnosed formally as a melanoma by the dermatopathologist or treating clinician here. So the tests can go from DiffDx to DecisionDx melanoma when this is appropriate and can inform management decisions. So again, this leads us to the second portion of the talk, the DecisionDx melanoma test that's designed for invasive cutaneous melanoma. Not to belabor this with this audience here, but the majority of patients who are diagnosed with invasive cutaneous melanoma are diagnosed at early stage. And dermatology is excellent at identifying early melanoma, and we have many tools that are designed to really catch melanoma early with dermoscopy, total body photography, and excellent skin exams in dermatology clinics. And so 92% of patients are actually stage 1 or stage 2 at the time of initial diagnosis. However, what can be missed by a staging approach only is that patients who have stage 1 or stage 2 disease, fundamentally patients without a positive sentinel lymph node, actually make up about 60% of the melanoma deaths if you exclude patients who are stage 4 at the time of diagnosis. And so fundamentally, what we're proposing here is that patients who are diagnosed at early stage actually experience poor outcomes, and that if we had prognostic tools that could provide more accuracy to prognosis, this could actually inform management decisions for the benefit of patients and identify patients at earlier stage who may go on to experience outcomes of interest that could affect management decisions. And this could have impacts for patients because a recent study actually just from late last year from a Canadian group, Ibrahim et al., identified that patients who had asymptomatic imaging, who had imaging to detect asymptomatic recurrences had about a twice as high likelihood of survival than patients who had symptomatic recurrences identified. And so essentially the early identification of recurrence can have impacts for patient survival. So DecisionDx melanoma was developed to assess risk of recurrence that's independent of traditional clinical pathologic factors, that's fundamentally based on the tumor biology of the lesion in question. And what it is based on is a 31 gene expression profile assay using RT-PCR to produce 4 discrete class calls: the class 1A, the lowest risk, class 1B, class 2A, and class 2B, recognizing the highest risk of the gene expression profile assay for patients with invasive cutaneous melanoma. And there's a robust range of clinical validity and clinical utility evidence that supports the use of the DecisionDx melanoma assay to inform management decisions for our patients. And it can really address a range of important management decisions for the patients that we take care of with invasive cutaneous melanoma. And for the purpose of this talk, we'll focus on 2 important clinical decisions that can impact treatment plans. First, guiding sentinel lymph node biopsy, and then assessing the risk of recurrence to inform important decisions around intensity, a follow-up, whether we're dealing with a patient who has a low risk or a higher risk to develop guideline appropriate management plans based on that risk of outcomes of interest. So first on the discussion of sentinel lymph node biopsy prediction. Currently, the guidelines for sentinel lymph node biopsy are really intended to direct sentinel lymph node biopsy for patients who have a greater than 5% likelihood of sentinel lymph node biopsy positivity. And based on pathologic stage, this speaks to patients who are T1B and above, and also a subset of patients with T1A tumors with high-risk features such as lymphovascular invasion, uncertainty of microstaging, or a very high mitotic rate. And what's important to highlight here is that the sentinel lymph node biopsy procedure can add important prognostic information for patients, but that the majority of patients who receive the sentinel lymph node biopsy actually obtain a negative result. So 88% of patients we estimate who obtain a sentinel lymph node biopsy actually have a negative sentinel lymph node biopsy and don't obtain additional prognostic information based on that procedure. So in a cohort published in 2019 with 1,421 patients by Dr. John Vetto and colleagues really highlighted a prospective study that could identify patients who are at low risk for having a positive sentinel lymph node. And this has been recently expanded upon with another cohort of over 1,600 patients, leading to over 3,000 patients that we've been able to analyze with T1 to T2 disease to really identify if we could select patients who would have a low risk of sentinel lymph node biopsy positivity. And what we found is essentially that using the the Castle class, the DecisionDx-Melanoma test, you can identify a group of patients who have a low risk of sentinel lymph node biopsy positivity when you stratify these patients by their age. So specifically in patients who are 55 years and older with a class 1A result, they had a below 5% risk of a sentinel lymph node biopsy positivity in this study cohort. And patients over 65 had a less than 2% risk of sentinel lymph node biopsy positivity. And so based on that 5% threshold, might not benefit from a sentinel lymph node biopsy enough to warrant the procedure being performed. On the other side of this, the class 2B score, even in this same aged cohort, had above a 5% risk, and in fact above a 10% risk of sentinel lymph node biopsy positivity, and could suggest a group of patients who would significantly benefit from obtaining a sentinel lymph node biopsy to add prognostic information for the management of these patients. So moving on to decisions about that are guided on the risk of recurrence for patients with invasive cutaneous melanoma that can be obtained with a gene expression profile test, DecisionDx-Melanoma. So when we're counseling patients about their risk for outcomes of interest, if we turn to the AJCC version 8, we obtain information about melanoma-specific survival. However, melanoma-specific survival is not the only outcome of interest or importance for patients and clinicians, and gene expression profile testing can add information that's in addition to melanoma-specific survival. But if we just look at melanoma-specific survival for the purpose of this chart, this tracks nicely from stage 1, stage 2, stage 3 in the AJCC population. However, if we layer on DecisionDx-Melanoma class score, it can actually articulate significant differences from the predicted rate of the patient by stage. So even in patients with stage 1 disease who have an excellent 5-year melanoma-specific survival, patients with a class 1A result had an even better 5-year survival and can be additionally reassured in this cohort. And if they have a 2B result, their survival is actually, in the study referenced below, it's more similar to that of either stage 2 or stage 3A patient here in this cohort. And in the same way, patients with stage 3 disease with a class 1A result had a much better melanoma-specific survival than did patients with the class 2B result. So again, the DecisionDx-Melanoma test GEP score can be used to essentially refine this risk as would be predicted by the patient's stage with their melanoma-specific survival. However, as I mentioned, there are other endpoints of interest that guide important decisions for patients with invasive melanoma that speak to the recurrence-free survival and the distance metastasis-free survival, for example. And the DecisionDx-Melanoma test has had consistent results across archival, retrospective, as well as multiple prospective studies that demonstrate how the DecisionDx-Melanoma score can be used to produce discrete risk groups within patients with class 1 and class 2 results from the DecisionDx-Melanoma test. And so you can identify class 1A, class 1B, class 2A, and class 2B patients that have significant differences in their recurrence-free survival and distant metastasis-free survival. And these trends are consistent across the range of these papers. I want to focus for the purpose of this talk on the largest study to date, a recent meta-analysis published at the end of 2020 by Dr. Greenhaw and colleagues that really identified 1,479 patients across 4 different cohorts that in the meta-analysis was really looking about how the gene expression profile test can be integrated with clinical pathologic factors to provide improved risk prediction for patients with invasive melanoma. So overall in this meta-analysis, the recurrence-free survival and distant metastasis-free survival seen in these KM curves above. The class scores, the class 1A, class 1B, class 2A, and class 2B were stratified into discrete risk groups with significantly different rates of recurrence and distant metastasis. So in the class 1A group, the distance metastasis rate was 5.5%, and in the class 2B group, it was 38.8%, which suggests a meaningful difference in event rate in the class 1A compared to the class 2B population in this study. So the class 2B specifically had the strongest hazard ratio in multivariable analysis, and importantly is statistically significant even when taken into consideration with other clinical pathologic factors that we know to be important for prognosis, such as breast low thickness, ulceration, age, and sentinel lymph node biopsy status. And specifically when compared with sentinel lymph node biopsy status, and even when combined with sentinel lymph node biopsy, the gene expression profile test can add additional information that can help refine prognosis for these patients. I want to highlight that in this meta-analysis, sentinel lymph node biopsy is adding important prognostic information with a sensitivity and specificity seen here of 57 and 74%. So sentinel lymph node biopsy performing well in this meta-analysis. And even so, the gene expression profile test, when combined with a sentinel lymph node biopsy, can produce a greater sensitivity and specificity and an improved negative predictive value for recurrence-free survival and distant metastasis-free survival. So essentially articulating how gene expression profile testing can be integrated with the current work that we do to refine prognosis for our patients. I want to highlight one aspect of this data as well from this meta-analysis that really focuses on the sentinel lymph node biopsy patients. So here, this KM curve describes 555 patients who were eligible and assessed by sentinel lymph node biopsy who had a negative sentinel lymph node. And within this group, 61% of the events in this cohort had 2B results. So essentially, the sensitivity here of the Castle DecisionDx melanoma test is 61% for recurrence events in the sentinel lymph node biopsy negative population. In this trend, it holds for distant metastasis as well, where 54% of the events in the sentinel lymph node biopsy negative population, those patients had a class 2B result. So I think that this evidence demonstrates how even in patients with a negative sentinel lymph node biopsy, the DecisionDx melanoma score, the class 2B result can add important information to identify a group of patients who in this study had a high rate of both recurrence events as well as distant metastasis events. And I think this is important for patients who have a negative sentinel lymph node in this study. And then finally on DecisionDx melanoma, a recent expert panel publication from Dr. Quatra and colleagues articulated how the 31 GEP test, the DecisionDx melanoma test, can be incorporated into management for patients when you're using the patient's stage to refine your treatment based on the patient's risk of recurrence. So essentially what the value of this study articulates is that you can identify patients who will basically benefit from gene expression profile testing based on both their tumor characteristics, but also some of the specific characteristics of the patient. So it breaks down how the gene expression profile test can be integrated into management for patients based on their clinical stage, but also based on their patient characteristics. So if you have a patient who is looking for additional reassurance, the gene expression profile test can add that reassurance for a particular group of patients. And in the same way, if you have a patient who's really looking for more data about endpoints of interest, such as recurrence-free survival or distant metastasis-free survival, the gene expression profile test can add important prognostic information to help refine the treatment that is based on the clinical stage combined with the gene expression profile result. It also, I think, importantly highlights the role of multi-specialty or multidisciplinary care teams to really help make informed decisions about patient care and can use the gene expression profile information conscientiously and integrate that into patient management plans at a high level. So overall, the DecisionDx melanoma has a robust underlying evidence that supports its clinical use with over 5,700 patients that have been included in both retrospective and prospective studies, over 26 to date. And for clinical testing, over 59,000 patients have been tested from over 6,800 clinicians here in the United States. And the strength of the evidence has led to Medicare approval for this test and is clinically available for the benefit of patients and clinicians who are making decisions guiding their care. So for the last section of this talk, I'm going to just speak briefly on DecisionDx SCC, which is for patients with cutaneous squamous cell carcinoma with one or more high-risk features that was just launched at the end of August here. So I know this is shifting gears from the talk here today, but cutaneous squamous cell carcinoma is an emerging problem here in the United States, and based on the high incidence of cutaneous squamous cell carcinoma, has a significant disease-related mortality in the United States. And unlike melanoma or breast cancer, squamous cell carcinoma does not have other personalized tests that can add value by using gene expression profile to produce a more refined sense of patient risk of poor outcomes. And current staging relying on clinical factors or clinical staging systems have a low positive predictive value for identifying patients who will go on to experience poor outcomes. And so the unmet clinical need is developing gene expression profile tests that can add in this prediction to identify patients who will go on to have these poor outcomes. So fundamentally, the DecisionDx SCC test is intended for patients with cutaneous squamous cell carcinoma with one or more high-risk factors to help inform individual risk of metastasis to then guide risk-appropriate management decisions. Now, the high-risk factors in squamous cell carcinoma are, of course, different from those in melanoma, and speak to things that are identified both on clinical exam as well as on review of histopathology. So tumors with a very large size, over 2 centimeters, patients who are immunosuppressed, as well as some histologic findings such as perineural invasion, poor differentiation on histology, or very deep invasion. All of these are considered high-risk factors that could identify to clinicians which patients might benefit from gene expression profile test information to refine their risk of metastasis. So the DecisionDx-SCC test is a 40-gene gene expression profile assay that uses a validated neural network algorithm to produce one of 3 class calls: class 1 or a low biological risk, class 2A with a moderate biological risk, or class 2B with a high biological risk as a result of testing. The evidence that supports the DecisionDx-SCC test has also been published. The discovery, development, and validation is published in a paper by Dr. Weissong et al. In the JAD of this past year. And several clinical utility papers have also been published. And I'll also be presenting some data that remains unpublished here from Castle in the upcoming slides. So the DecisionDx-SCC test is fundamentally validated to predict metastatic risk for these patients with cutaneous squamous cell carcinoma and 1 or more high-risk factors. And as a result of testing, we identified 3 groups: the class 1, class 2A, and class 2B patients that had statistically significant event rates over the 3-year period of this validation. So that the class 1 patients had a 6.6% overall event rate of metastasis in this cohort, and the class 2B had a 52.2% event rate, speaking to the high positive predictive value of this assay. The distribution of the class calls is such that about half of the patients had a class 1 or low biological risk score, and about half had a class 2, class 2A, or class 2B class call in this study cohort. When we look at the statistical significance and the impact of this class call from the gene expression profile, we're looking to compare to the current risk factors that we use to guide our patient decisions. So on univariate analysis, some of the things that we know produce high risk squamous cell carcinoma, such as perineural invasion, deep invasion, and poor differentiation, were statistically significant, as well as the class 2A result, with similar hazard ratios to any of these independent features that we know are high risk. On multivariate analysis, the class 2A also remained significant in addition to poor differentiation and deep invasion, suggesting that the class 2A call can be integrated with the other known risk factors to produce a more refined sense of risk of metastasis for a patient with a class 2A result. And what's more, the class 2B result had an even stronger hazard ratio that's about 3 times the risk of any of the known risk factors here on univariate analysis, and this pattern holds up on multivariate analysis, really suggesting that the class 2B result can highlight patients who have a very high risk of metastasis and can be linked with these other risk factors to produce an even more refined sense of metastatic risk in patients with cutaneous squamous cell carcinoma, one of these high-risk factors, and a gene expression profile of class 2A or class 2B. So based on staging, currently there are different approaches that are used clinically. And if you have a factor-based approach where you're essentially adding up or summing clinical risk factors, the DecisionDx-SCC class call can be added to this assessment to produce an even more refined risk of metastasis. So here, with patients who had over 2 risk factors on the KM curve here on the right, this is a group of patients who have a high risk of events in the study cohort with a risk in the overall population here of almost 20%. However, the class 1 patients had about a 9% risk in this cohort, about half of the total risk in this group of patients, whereas the class 2B patients had a 50% event rate, and the class 2A patients had about 25%. So again, the class call can identify 3 discrete risk groups within patients who have over 1 or 2 risk factors that can be clinically meaningful when deciding how to manage these patients using a risk-based approach and thinking about the risk of metastasis. If you're using formal staging guidelines as well, such as Brigham and Women's or AJCC, we think that the gene expression profile test can add independent information that can further clarify the patient's risk of recurrence. So again, if you look at a group of patients who are either Brigham and Women's T2B or T3, the Castle class score of either 2A or 2B can add additional information to produce a more refined sense of this patient's risk of metastasis, even when you account for their Brigham and Women's or AJCC class score here on this multivariable analysis. So again, the purpose of this test is to integrate the gene expression profile test with the clinical pathologic risk factors to develop risk-appropriate management plans. And some of these plans may include, for your low-intensity patients, definitive surgery for all of these high-risk squamous cell carcinomas, as well as a clinical nodal exam, and then return to a follow-up interval that matches that of patients with a high-risk cutaneous squamous cell carcinoma. However, if in combination with the gene expression profile result and the clinical pathologic features, it's possible to identify patients who would benefit from a moderate intensity or even a high intensity follow-up plan based on this risk of recurrence that could include a greater intensity of nodal imaging or nodal evaluation effectively, as well as consideration for multidisciplinary clinics that could include colleagues in surgical oncology or even medical oncology, depending on the tumor characteristics, their gene expression profile, and their risk of recurrence. And so essentially, this information may inform management plans that can be more risk appropriate for patients with high-risk squamous cell carcinoma. And so I know that's a lot of information for a short discussion here, but I hope that I was able to present the molecular program that we have here at Castle Biosciences that really aims to address important and clinically impactful cutaneous malignancies, and that these tests are designed to inform difficult management decisions for clinicians for the benefit of patient care. On the diagnostic side, with the DecisionDx DiffDx melanoma test for these difficult to diagnose melanocytic lesions, the DecisionDx melanoma test for patients with invasive cutaneous melanoma, and the DecisionDx SCC for patients with cutaneous squamous cell carcinoma with one or more high-risk factors. And so I thank you for your attention, and I hope that we have time for some additional questions here. So I'm going to turn to the chat here. All right, so first question here on the DiffDx melanoma test, looking at 18 as a cutoff. And the question here is, some in clinical practice use puberty as a cutoff for adults in terms of biology. And in this cohort of the Spitz-Nevi that were classified as malignant in the validation cohort, those were all in patients under the age of 8. So we did not have patients age 14 through 18 in the validation cohort. And I do think that the question here is it worth moving the age delineation? I think that's a fantastic question and something that we're really focused on through future research, where we're going to focus on the pediatric population and the application of the DiffDx melanoma test, specifically in pediatric patients, looking at Spitz-Nevi, spitzoid melanoma, and pediatric melanoma to really identify where that cut point can be. And 18 at this time is really focused on where the bulk of the patients are in the validation. And until we can move the test range earlier, we'll keep it to 18, but that's a great question. Puberty could be a more appropriate endpoint because, again, those misclassified cases in the validation were limited to the under 8 population. Okay, another test question here just about the DecisionDx DiffDx melanoma I'll focus on first. Looking at the MGF rate, and the MGF rate is similar in the DiffDx melanoma validation as it is with the other products. We have a lot of experience in the Castle Biosciences lab to have robust assays that have a good ability to extract RNA from the form of fixed paraffin embedded tissue. And the success rates are even higher actually for some of the other assays in clinical use. But the 3% range, I think, is an expected range that we can anticipate this to be effective. And I think for the DiffDx melanoma test, that rate is so high of technical success because the cutoff for testing performance is actually 10% tumor content. And so it can be focused on lesions where there's a smaller amount of material fundamentally, and the test has robust processing effectively to be able to produce a score even in the setting of small lesions. So I think that the performance of the assay should be expected to be in that range based on the experience with using those results. have a question here. So I have a patient with a 0.5 millimeter breast low on a shaved biopsy with a class 2B. Would it be wise to actually recommend on our pathology report to do a sentinel lymph node biopsy, or is that mentioned somewhere in your report? That's another good question. I think that, at Castle, the reports are not prescriptive about what must be done clinically as a result of the test. It's really, we present the information, the strength of it, we believe, will helps clinicians interpret it in the context of their practice to then have that inform their management decisions. We're working on updates of our report, which will hopefully be forthcoming, to provide some additional clarity around how the clinical pathologic factors can be integrated with the Castle class score to provide clearer sense of the patient's risk of risk of sentinel lymph node biopsy in our large data sets. And some of that, for example, in this example of 0.5 millimeters in a class 2B, it may depend on the patient age as well to guide the strength of your recommendation, whether that's in the 5 to 10% risk range or greater than 10% risk range, which may change how you counsel this patient. So at present, the information is presented really in a descriptive way about the strength of the evidence that we have, and then having physicians integrate that into their practice based on their assessment and interpretation of the data and the patient's preference as well. So I think that looking to that Quattro manuscript that I was referencing could be helpful to kind of think about how to integrate this into practice, thinking about the tumor in question and combining that with the Castle class score. Another question here about spindle cell squamous cell carcinoma and whether or not DecisionDx-SCC can be applicable to those cases. And so there's another aspect of this here talking about using cytokeratin stains or other special stains to characterize these as squamous cell carcinomas. I will highlight that a definitive diagnosis of cutaneous squamous cell carcinoma is required to run the DecisionDx-SCC test. 100% of the cases that were included in testing and validation were confirmed to be cutaneous squamous cell carcinomas. So that's an entry point to have the test run. Spindle cell is considered to be an aggressive subtype of squamous cell carcinoma, potentially linked to poor outcomes. And so that is considered to be a high risk factor and would allow testing for the DecisionDx-SCC. What's more is that often spindle cell squamous cell carcinomas can be deeply invasive or have poorly defined borders. And so those are other factors that could motivate testing for DecisionDx-SCC. But I think it's a great point that it must be confirmed to be a squamous cell carcinoma in order to allow testing. Looking at another question here about squamous cell carcinoma, how we validate the impact of the test result on management. It's a great question. This test was just commercially released at the end of August. And so looking at how this will affect management decisions is something that we're really focused on moving forward. We have ongoing prospective studies to further describe the test performance in clinical practice when addressing cutaneous squamous cell carcinoma, as well as looking at significant endpoints that are currently debated in the management of high-risk squamous cell carcinoma. So we're thinking about studies to address radiation therapy as a specific endpoint to really help to determine how the identification of tumors that are at higher rate of metastasis or higher risk for metastasis might be managed differently when you combine their risk factors and the gene expression profile test. So definitely something that we're going to be focused on to ensure that we can evaluate how this will impact management decisions. I think that those are the questions that we have here. If there are others, please list them here. I think we have a little bit more time. I'd be happy to address any questions or concerns about the range of the three tests. So I don't see any more questions here that are coming up, but I do want to thank you all for your attention. I'll stay on until the end of time here, the end of the time here for this session, not the end of all time. But I really appreciate the attention today. This is one of the first times when we're presenting the full range of diagnostic and prognostic tests here that Castle Biosciences now has available. So I appreciate your attention across the range of those. products. And I hope that the rest of the meeting here for the conference goes well. Thank you again.